Okay, everybody, we're going to look at some neoplastic disorders, and we're looking at these because these are the leading cause of death from disease in children. The first one that I'd like to look at is leukemia. This is a proliferation of abnormal WBCs. We're looking at leukemia because it is the most common childhood cancer. Leukemia is classified according to the predominant cell type. We have if it has the word lympho in it, it's affecting the lymphatic system. If it has myelo, it is affecting the bone marrow. So if it's acute and blastic, it is referring to immature cells. And if it is chronic or cytic in nature, it is referring to the mature cells. We have two different types that we're going to talk about. The first one is ALL. This is acute lymphocytic leukemia. So these are immature cells that are invading the lymphatic system. We typically see this in 2 to 5-year-olds. That's the peak age of it. It is more frequently seen in boys, and it is more frequently seen in the Caucasian race. This is the most common form of leukemia that we see, and it does have an 80% survival rate. The second type of leukemia is AML, acute myelocytic leukemia. So this again is acute in nature, so immature cells, but since it's myelocytic, it's invading the bone marrow. 20% of our leukemia cases are AML. The pathophysiology of leukemia, the cause is unknown. Stem cells in the bone marrow produce immature WBCs that cannot function normally. They proliferate rapidly by cloning, causing bone marrow to fill with abnormal WBCs. These cells will then spill out into the circulatory system, and they replace the normal functioning WBCs. Leukemia assessment. The major problem is leukopenia. And leukopenia is decreased WBCs, increased blast. So remember, the blast cells are the overproduction of immature, poorly functioning white blood cells. The other thing that we see with leukemia on assessment is bone marrow dysfunction. And that can be found on page 310. You'll see the figure 44-3. And it kind of looks at all of the effects of acute leukemia. But as far as bone marrow dysfunction, so when our bone marrow becomes infiltrated, we see neutropenia. So they're at risk for multiple prolonged infections. So we have a deficiency in the mature WBCs. We'll see anemia, so a deficiency in RBCs. And again, think of those signs and symptoms for anemia: pallor, weakness, irritability, shortness of breath. With bone marrow dysfunction, we'll also see thrombocytopenia, so a deficiency in platelets, and that's where we see those bleeding tendencies and bruising. We'll also see an infiltration of the reticuloendothelial system, and again, it's going to affect the hepatic organs, the spleen, enlarged lymph nodes in the abdomen. They'll complain of abdominal pain. We're going to see the leukemic invasion of the central nervous system. Meningitis, increased intracranial pressure. CNF analysis is used to determine if any CNS involvement. And then we have leukemic invasion of the bone. We'll see pain and or pathological fractures. Again, you guys, around page 1310 is where you're going to see that in the text. The therapeutic management of leukemia is on page 1311. We'll do IV and chemotherapy. There are 3 phases of therapy, and the book talks about these phases. We have induction phase. This is 4 to 5 weeks, and it begins almost immediately. We have the intensification or consolidation therapy. That is where we try to eradicate all residual leukemic cells. And in this phase, it's chemotherapy given periodically over 6 months. And then we have the maintenance therapy, which is to preserve remission. So weekly or monthly CBC, so we'll see what's going on in their complete blood count. Treatment usually stops after 2 to 3 years, but we still monitor them for a prolapse, or I'm sorry, a relapse. We also use some CNS prophylactic therapy. This is used in high-risk children to reduce the risk of leukemic cells taking over the CNS. We could do reinduction after relapse. Each relapse means they have a poorer and poorer prognosis. Testes are resistant to chemotherapy and may lead to relapse. Relapse in testes leads to intensive chemotherapy and irradiation. And then the other way we therapeutically manage leukemia is a bone marrow transplant. And we use a bone marrow transplant both in ALL and or AML. And these are our problem issues that we worry about. Risk for infection related to neutropenia. Again, those deficient WBCs, we've got a proliferation of the immature WBCs. So when they first come in, their WBC, it's going to be extremely high. As we give them chemotherapy and prepare them for a bone marrow transplant, don't forget what happens to the WBC. It goes down to 0. That's what leads them to be neutropenic. More heightened precautions are in effect for infection. Risk for injury related to thrombocytopenia. Don't forget that's our deficiency in platelets, so we're worried about bleeding. Altered nutrition. We'll talk about how chemotherapy alters their appetite. And don't forget, with leukemia, it will increase the metabolic rate as well. Pain. Activity intolerance, again, activity intolerance because of the deficiency in the RBCs. So that affects our oxygenation. We'll see self-esteem disturbances, anticipatory grieving, and then knowledge deficit as well. Self-esteem disturbances related to disease process and treatments, anticipatory grieving related to this life-threatening illness, and then knowledge deficit related to everything, the diagnosis, the treatment, the prognosis. Let's see, pain related to disease process and treatments, activity intolerance, I mentioned, related to anemia, but also infection because they are at risk for infection. All right, how are we going to treat all those issues? Okay, we need to maintain an infection-free state. Again, why do we need to do this? Because they're neutropenic. Remember we talked about an absolute neutrophil count back in oncology in 105. Absolute neutrophil count is less than 500. If they're less than 500, they're considered neutropenic, okay? And that's less than 500 cells per microliter. The norm here is greater than 1,500. Remind me when we get back to face-to-face and we're reviewing our hematologic, immunologic content, but you'll need to figure out an absolute neutrophil count, and I'll teach you how to do that. It's basically, you take the percent of neutrophils, or the segs, and you add that to the percent of the band cells. Whatever those two equal together, you times them by the WBC, and then you divide all that by 100. Again, I'll go over that in class with you guys. All right, so how do we maintain an infection-free state? We've said most of these things with all of our other disease processes, but standard precautions, good hand washing, meticulous oral hygiene, record vital signs, especially the temperature, and then think about what happens to our other vital signs with sepsis. Heart rate goes up, respiratory rate goes up. Provide good skin care. We would want to restrict staff and visitors with infection, protective isolation. Discharge planning, we would want to talk about when do they go back to school. We do want to isolate them from chickenpox and other communicable diseases, so you think about that when we talk about returning to school. We think about what vaccines they should not be receiving during this time. We think about siblings in the house, what vaccines should they get or should they not get at this time as well. Our next one is to prevent injury, and don't forget we're preventing injury because of those low platelets. So we've talked about some of these things before as well. Avoid IM and IV injections if we can. Do not give aspirin, soft toothbrushes, avoid rectal medications and temperatures, and again, supervision, right? We need to supervise these kids to keep them safe. Promote adequate nutrition. Again, why is their nutrition inadequate? Well, because of the treatments with the chemotherapy, they could be nauseous, they could be vomiting, they could be having diarrhea. Because of some of the treatments, they could have mucositis, so those ulcerations, those mouth ulcers, and they go down the esophagus. And then we talked about the increase in their metabolic rate. So how do I want to promote adequate nutrition? I want to feed them high caloric, high protein, high iron foods. If they are neutropenic, don't forget about what that means in our diet. We need to remove fresh, raw fruits and vegetables from their diet. Remember, they can have thick-skinned fruits as long as somebody else is peeling them for them. We want to encourage extra fluids to prevent constipation or dehydration. We want to allow the child to select favorite foods that are tolerated and that are appropriate choices. Make sure we're doing small, frequent snacks and encouraging dietary supplements. As you guys know, with adequate nutrition, we're always monitoring their I&O and their daily weight. Some other options we could do is give them antiemetics to help treat nausea. We can offer local oral anesthetics before meals to allow the child to eat without pain from mucous membrane ulcers, and giving them choices so they feel like they have some control over something. And then don't forget, we very well may start TPN because their oral nutrition is probably going to be inadequate. Relieve pain. Don't forget they have pain from mucositis, and if they have any bone pain, so pain from any source. Offer supportive alternatives, company, distraction, heat or cold, whatever would be appropriate in this situation, maybe gentle massage, for mucositis, soft toothbrushes, saline rinses, and don't forget they could be on a patient-controlled analgesic as long as they're old enough to understand how to use it. We want to medicate regularly before pain becomes excessive. With oncology patients, around-the-clock dosing is best. We could consider conscious sedation, midazolam or fentanyl for spinal taps and or bone marrow aspiration. We could use a beanbag chair for them for positional changes. Kids like to use those a lot. And also avoid excessive stimulation, decrease in noise and light. When we look at our goal to conserve energy, again, we're thinking of a decrease in those RBCs because the bone marrow's been infiltrated. Cluster care to prevent exhaustion and provide rest periods between care. All right, we're promoting self-esteem. Why could their self-esteem be diminished? One of the big reasons in our pediatric population is alopecia. So other ways that we can overcome this are to provide realistic feedback on the child's appearance, offer suggestions such as wigs or scarves or hats to cover the alopecia. We want to encourage them to be as independent as possible. That promotes self-esteem. We want to give lots of positive reinforcement to enhance the child's sense of accomplishment, provide diversional activities as tolerated, and encourage early return to peers or school to avoid social isolation. Again, we talked about the use of technology, how that's really helpful in that piece now. And again, we want to promote self-esteem because we want to hopefully keep our growth and developing moving along, but we very well could see delays in growth and development, especially the younger the child. Your evaluation, oh, sorry, I think I skipped one. Prevent complications related to leukemia. Again, some of those complications, prolonged immobility or treatments which can exacerbate disease process. You guys want to make sure you're inspecting the skin for any breakdown. You're anticipating the needs for multiple transfusions of platelets and RBCs as needed. We want to check for hemorrhagic cystitis. If we're giving cyclophosphamide, hemorrhagic cystitis is a very common side effect. We want to give them lots of fluids and we want to irrigate their bladder. So we would insert a 3-way Foley catheter and put bladder irrigation into their bladder. We want to monitor for constipation, although it's typically the opposite. We're typically managing diarrhea for these patients. So again, diarrhea, skin breakdown, we're doing some sort of early protective barrier before it becomes an issue. We need to make sure that we are monitoring for peripheral neuropathy, especially if vincristine is given. And then there is an 80% cure for ALL. We would want to discuss bone marrow transplantation and also stress to parents that loss of remission does not necessarily mean the end. And your book does talk briefly about a bone marrow transplant, and that information should be a review for you, and that's on page 1311. Now, if we look at our evaluation piece of it, hopefully the child is maintained in an infection-free state. Injuries are prevented or kept to a minimum. Adequate nutrition is maintained. Child is free from pain or can live with minimal level of pain. Energy is conserved and mobility maintained. Child's self-esteem is maintained. And again, don't forget, treat the child as living, not as they're dying. Any complications are prevented or we've kept them to a minimum. And positive coping mechanisms are utilized by child and family to deal with this illness.